Good morning, everyone. I'm Tamiko Brown-Nagin, the Dean of the Harvard Radcliffe Institute, and it's my pleasure to welcome all of you, whether you're joining us in person or online, for our annual Gender Conference, focused this year on gender and mental health. Now, our program began last night with a performance and conversation with the acclaimed musician and mental health advocate, Ezra Furman. The performance was amazing, and it was accompanied by a thought-provoking conversation, and I want you to know that a recording of both will be available online in the coming weeks for those of you who may have missed it. Today, we're going to continue our exploration of the relationship between mental health and gender through a series of panels featuring scholars, physicians, scientists, writers, educators, artists, and activists. Mental health is inseparable from our overall health and well-being. As the World Health Organization explains, mental health is, quote, intrinsic and instrumental to the lives of all people. It's neither static across one's lifetime, nor is it a binary state. Mental health is influenced by a range of factors, from individual characteristics like genetics to broader family, community, and structural determinants. Some, like access to quality education and safe living and working conditions, can protect mental well-being. Others, including poverty, racism, discrimination, and gender inequity, can harm mental health and place marginalized groups at greater risk. Today, the world is facing what the UN Secretary General has called a, quote, global mental health crisis. The COVID-19 pandemic interrupted access to mental health services while simultaneously causing many people to experience symptoms of anxiety, post-traumatic stress, and depression. And the World Health Organization's 2022 World Mental Health Report underscore the ongoing risks to mental health posed by global issues, including social and economic inequality, public health emergencies, humanitarian crises, and yes, climate change. These issues compound long-standing challenges to mental health. Even before the pandemic, nearly 1 billion people had a diagnosable mental health disorder. That's right, 1 billion people, which is quite a lot. Yet, globally, mental health care has long been underfunded, leaving gaps and inequities in the quality and availability of services. Here in the United States, it's estimated that more than 1 in 5 adults had a mental illness in 2021. Less than half of them received care in the past year, and among men and people of color, the percentages of adults receiving care was lower than among women and white adults, respectively. Many people are unfamiliar with the mental health care system, and almost half of Americans live in an area with a shortage of mental health practitioners. Rising demand for mental health services throughout the pandemic has further strained the system, leading to longer wait lists and provider burnout. But access to care is also limited by cost, stigma, and discrimination. And the crisis has not affected all Americans equally. In 2021, the Surgeon General issued a public health advisory reserved for the most serious health issues requiring immediate national attention. About youth mental health. This February, the CDC released a new report which found that 42% of high school students and 57% of high school girls experienced persistent feelings of sadness and hopelessness in the past year, 57%. LGBTQ youth also faced increased risk of anxiety, depression, and suicide due to stigma, discrimination, threats of violence, and lack of social support. In a 2022 study by the Trevor Project, a staggering 45% of LGBTQ youth surveyed in the United States reported having seriously considered suicide in the preceding year, with even higher rates for transgender and non-binary youth and LGBTQ young people of color. Lest anyone question the importance of societal factors in these figures, it's important to note that rates of attempted suicide were substantially lower among youth who felt supported by families, schools, and communities. Nevertheless, so far in 2023, more than 460 anti-LGBTQ bills have been introduced in state legislatures, according to the ACLU. It's difficult to overstate the urgency of the mental health crisis that we face, but we're not helpless to address it. To the contrary, as our speakers delve into the complex relationship between gender and mental health, we must also consider where we go from here in addressing this generational challenge. This imperative motivates our convening today. In our first session, panelists will show how mental health is a matter of public health and explore what this means in practice. Our second panel will examine gender and mental health with an emphasis on adolescence, after which we'll break for lunch. We'll reconvene for this afternoon's keynote by model, trans advocate, writer, and speaker Devin Norell, who will be joined in conversation by V. Varun Chaudhry, Assistant Professor of Women, Gender, and Sexuality Studies at Brandeis University. Following the keynote, our third panel will reflect on gender and the impact of current social justice issues on mental health. Finally, we'll conclude with a panel on resilience and prevention. We welcome your thoughts throughout the program, whether you're watching in person or online. You can submit questions using the Slido link that is behind me and post it in the chat feature on the Zoom webinar. We'll start our first session in just a moment, but first, let me offer some thanks. I'm grateful to all of our speakers and moderators for sharing their knowledge and perspectives on this critically important topic. I want to also thank today's faculty organizers of the event, Immaculata DeVivo and Carol Oja, as well as the many Harvard faculty and staff who contributed ideas throughout the planning process. Thanks as well to Rebecca Wasserman, Executive Director of Academic Ventures and Engagement at Radcliffe, Jessica Vicklin, Director of Events, and their entire teams. Let me also recognize members of the Radcliffe Institute Leadership Society and all our annual donors. Your generous support keeps Radcliffe programming free and open to the public, and we thank you. I also want to gratefully acknowledge the Perrin Moorhead Grayson and Bruns Grayson Dean's Leadership Fund for Academic Ventures, which is supporting today's event. With that, I'm pleased to kick off our first session, which will be moderated by my colleague and friend, Michelle Williams. Michelle is Dean of the Harvard T.H. Chan School of Public Health and Angelopoulos Professor in Public Health and International Development with a joint faculty appointment at the Harvard Kennedy School. An expert in reproductive, perinatal, pediatric, and molecular epidemiology, Michelle has published more than 500 peer-reviewed research papers, and she's a member of the National Academy of Medicine, the Society for Epidemiologic Research, and the American Epidemiological Society. Her numerous honors include the Harvard Chan School's Outstanding Mentor Award and the White House's Presidential Award for Excellence in Science, Mathematics, and Engineering Mentoring. Now, please let's give a warm Radcliffe welcome to Michelle Williams and the panelists. Thank you.
Thank you, Tomiko. Good morning, everyone. Our panelists join. Let me just share a few remarks. I'm really looking forward to the time that we have to explore the topic, mental health equals public health. So for this opening session, what are we going to do? We're going to try to paint a picture of the complex mental health landscape in this country. Our discussion will tackle the topic with an intersectional perspective, with a focus on youth, women, underserved communities, and social justice issues. We will discuss the burdens created by the various forms of stigma, including those that are individual, societal, and systemic. And we will discuss the urgent need for earlier intervention and a health system that enables Americans with mental health illness to assess vital resources. We will discuss how mental health issues play out across the lifespan, including at the important intersection of gender, dementia, and depression. As a whole, our session aims to dismantle the dysfunctional and piecemeal approach to mental health in this country. We are here to look at the big picture. We are here to connect the dots. We are here to look at disparities of race, ethnicity, and gender. And we are here to declare that mental health matters at a population level, and that people deserve public policies that acknowledge and address the severity of the crisis in this country. Because as the title says for this panel, mental health equals public health. So let me now briefly introduce our distinguished panelists. Rahn Bailey is the chair of the Department of Psychiatry at Louisiana State University, New Orleans School of Medicine. Olivia Okereke is an associate professor of psychiatry at Harvard Medical School and an associate professor in the Department of Epidemiology at the Harvard T.H. Chan School of Public Health. And Esmé Wang is a writer and founder of the Unexpected Shape Writing Academy. For this panel, we'll have each speaker present their remarks for about 10 to 12 minutes. Then I'll have the privilege and honor of moderating a discussion for about 15 minutes. And then finally, we will have 15 minutes for questions from the audience. Audience members, as you've heard before, you are welcome to submit your questions at any time during this session, and we'll get to as many of them as possible. And whether you're here in person or those of you who are online, welcome to you as well. Please make sure that your questions are entered here in person on the Slido link, and for those of you online, to please include your questions on the chat function. So I'm going to have now an opportunity to begin with having Rahn, as a psychiatrist, will start the presentation.
Well, thank you very much, Dean Williams, our moderator, and Dean Brown-Nagin for having me. As mentioned, I'm Rahn Bailey. I currently chair psychiatry at LSU School of Medicine, New Orleans. Also in the role of assistant dean for diversity and community engagement. So it really warms my heart to have opportunity to discuss really what I do for a living, really work trying to find ways to improve the lives of people, address problems that I think often are more systemic than individual, although psychiatry is a set of the individual, and really find ways to address, I think, some considerations that I think we in healthcare have some particular value, I think, to bring to the equation. I'll also share how pleased I am to hear very early on the initial comments about how these really are public health initiatives. We, I think, have finally moved past the Rubicon of a consideration that a problem all too often starts in what the individual has done or has not done individually. I think all too often many of the external variables that I think affect many, particularly so-called social determinants of health, go a long way toward having adverse implications of persons psychiatrically. And I think in many regards that's much of what we do in psychiatry. My task today is to discuss issues regarding psychiatric illness in women. I spent a huge part of my career addressing much of the athleticism and in many regard the unfairness and how we often handle concerns regarding psychiatric illness in women and how we have historically not really treated them very, very well. That being said, we'll begin, and I have no disclosures for today's discussion. Fully 20% or 1 in 5 U.S. women will at some point in their adult life between the ages of 18 and 65 meet criteria for a psychiatric disorder. I often begin by arguing that psychiatric disorders have across a full lexicon of considerations. They are not by definition all, i.e. the most severe forms of illness, including psychotic disorders. We do see a highest rate of these difficulties in young women in their 3rd decade of life, very often misunderstood as being stress-induced. The concept being that there's a psychosocial stressor externally that's the cause of the problem. So all too often persons don't get adequate or optimal treatment because someone outside thinks that we can just make the stressor go away or you can just handle the stressor better, then the baseline biological considerations really don't play a role. A few key issues, I think, as far as it pertains to women. You do see a lot more internalizing of symptoms. We've had data, I think, throughout the entirety of my career that you tend to see a lot more persons presenting with physical health concerns more so than acknowledging that they are a mental health issue. Early in my career, I was doing residency. I would work, I guess, called a moonlighting job at a primary care clinic. I thought it was actually kind of interesting. I was a psychiatrist in training, but if persons thought I was a general medical clinician, they actually would speak to me differently. They put on an initial complaint sheet that their problem was a headache or a stomach discomfort, particularly gastritis, if you will, get behind closed doors and immediately begin to address what really bothered them. So I learned early in my career that we in psychiatry have to be open to hear people's concerns, understand what are the real problems that are pressuring them and causing difficulty, and recognize that all too often what's coming out as a physical issue, a pain or a discomfort, high blood pressure, things of that nature, may really be at its precipice of a psychiatric underlying concern that we cannot ignore. And if we ignore it, very often we don't move forward to providing better treatment. Now, there are a variety of variables that lead to these issues, some biological, some social, and I'll speak a bit today about aggression, agitation, and violence. We spend a lot of time in literature discussing hormonal fluctuations, particularly post-puberty. We do see a spike in anxiety and depression-related type symptoms. Socially, gender roles, a lot of discussion about that on yesterday, and our society all too often disadvantages people, I think very often as they are learning to address what gender they pursue, and women very often having other social concerns, earning less money than men, being more likely to be pushed into roles or jobs that pay less, more likely to be caregivers in families where everyone should share the responsibility, and of course sexuality kind of issues. More discussion, I think, by another speaker about violence. I spent a lot of time in my career on violence. I would just simply say here and in one other slide that more violence about women, more violence toward women, and unfortunately too much violence that's really not being adequately managed against women. Or too often, if there's a husband and a wife, for example, husbands historically in our country have been able to really get by with violence toward women that they're engaged in a relationship with or married to, that they couldn't get by with persons who they were not engaged in a relationship with or against another man. So these risk factors are relevant and increase the likelihood of a greater degree of psychiatric sequelae among women in our society. Now, how do we get to these issues regarding diagnostic disparities? And disparities certainly is a popular term for us now. We certainly consider the issue that diagnostically, if we don't understand what the initial problem is, we're unlikely to treat it optimally. Data make it very, very clear that across the full spectrum, in many areas, you see women having more presentations of affective illness, more anxiety, more clinical depression, pretty substantively. In anxiety disorders, which are the most common disorders in all of us psychiatry, about 1/3 versus 1/4, men versus women. More panic, more phobias, more post-traumatic stress disorder, more OCD. And clearly a big issue, more clinical depression. So that the rates of mental health disorders are higher, I think is key. And it's also important that it lasts over a full lifetime. So it's really not uni-specific for certain decades of one's life. In this particular work, we note that over the course of a lifetime, in just about every decade, we see more presentations of clinical depression that meet criteria in women than in men. So about 2 to 3 times more common an MDD diagnosis, Women tend more likely to be obsessive or to ruminate more about these concerns, and more likely, less likely, we note, to have an additional issue such as SUD or substance use disorders causing the problem. So the problem very often has a genetic basis, much more inherent, and less likely to be managed or treated optimally in standard settings. Unfortunately, this actually, I think, does bring forth the consideration of fatality. And we are seeing more fatalities and more suicide in our country in this regard. Probably more a higher peak in adolescents, especially, unfortunately, young African-American adolescent women than in other groups. Clearly, historically, we've always thought that there were more attempts at suicide by women than men, but more successful suicide, if we use that term, by men. And that's actually changed during my career. It used to be 3 to 3, and now it's 4 to 4. So fully 4 times as many attempts at suicide by women, 4 times as many successful suicides by men. And that tends very often to fall into the category of who tries to use a gun. So the real variable on who succeeds with suicide or not are all the considerations. And number 1, of course, is with a gun. Number 2, of course, is with suffocation or hanging. But when a gun is involved, men or women, and we're seeing more guns involved with suicide attempts with women, especially young women, you're more likely, unfortunately, to have a successful suicide. Rates of diagnosis, higher diagnosis prevalence in certain areas with women, more with eating disorders, almost about 4 out of 5, more GAD, or generalized anxiety disorder occurring over the course of a full year, more post-traumatic stress disorder after more violence in our society toward women, lower diagnosis prevalence in some other areas, less ADHD in women, less autism in young girls, and less SUD or substance use disorders. Although we are seeing a bigger peak, if you will, with this opioid epidemic, more fentanyl deaths. We actually have a so-called SOAR grant at LSU New Orleans where I work. We have 49 sites around the state really trying to address through SAMHSA funds the scourge of fentanyl exposure, dependence, and fatality throughout these rural southern states particularly. And this is a key issue, I think, for us kind of going forward. Easier access and, unfortunately, more use, we would argue, in women. And the final point, there are pretty similar rates in schizophrenia and bipolar disorder, key diagnostic concerns. I kind of end with psychiatric treatment. It goes without saying that we prescribe many agents in psychiatry. I finished med school at Texas in 1990. The entire industry or dollar value for psych meds was about $10 billion. Now, 30 years later, it's 10 times that amount. So many, many more people are prescribing agents, more types of prescribers, more prescribing in many settings, by psychs and by primary care and by physician extenders, and disproportionately we're seeing a lot more of that in individuals, of course, the full spectrum, who may present with anxiety-type disorders, very often women. So we see with rates of treatment, any mental disorders, you certainly see more in women. Those who took medications, about 1 in 5 or 20% women, and those who receive counseling or therapy, also a lot more likely to be women in this setting. So across the full spectrum, women accessing more care from psychiatrists, primary care physicians, and other extenders. But there are some treatment differences you should be aware of. Women more likely to seek help from a primary care doc and tend to see more specialty type services, more likely prescribed medications. We see a lot more men arguing against wanting to take medication, and less likely very often disclose hidden issues like alcohol use and being a victim of violence. Key themes for those of us in psychiatry to ask those questions, be mindful. I'd say even in educational settings like here at the university, in your health system, you should be thoughtful about these issues. When a young woman who's a student or an employee comes in and speaks about some considerations, ask these questions. Our data shows if you ask, you're more likely to hear and then develop the kind of trusting relationship between the patient and a doctor, where they may actually share issues that they may have thought that they were embarrassed to share. This has to be a setting where we do so. I kind of end, of course, with my big issue on violence, and the big issue, of course, is that when a gun is involved, you're a lot more likely to have suicide, I mentioned earlier, also a lot more likely to have domestic violence. Our data shows that whether you actually commit a domestic violence event or not, there's more domestic violence when there's a gun in the household or a gun in one's car. So a higher rate very often of trauma due to sexual victimization, due to against a romantic partner, and very often it shows up often in physical injuries. But we should again ask about the issue regarding whether they've been a victim of IPV or intimate partner violence. Went with some key hotlines, and of course I would argue, make the point in addition to the violence hotline and the sexual assault hotline that we have here, I'm very proud now to have worked with the SAMHSA Advisor Council on getting the 988 up and going. Very thoughtful. I think we're already seeing a substantial number more individuals who are calling that number, and that may actually lead to the kind of help that people need across the full spectrum of care. So thank you very much for your time and your attention. Really appreciate all your considerations regarding healthcare overall, but especially that we can do better in psychiatry as we care for, diagnose, and treat women in our country. Thank you.
Thank you. Thank you for opening up the session. Now I turn to you, Olivia, for giving us your remarks.
Hey. Well, thank you, Dean Williams, and thank you to the organizers and for everyone who is here in attendance this morning. My remarks today will address women and mental health in aging, specifically two conditions in aging that comprise the greatest share of the burden of mental health challenges in aging, which are depression and dementia. So in this discussion, I will also give particular attention to concepts of intersectionality in gender, race, and ethnicity, and the importance of applying life course perspectives. Women have a lifetime burden of depression, as we heard, that is twofold higher than that of men. And while this prevalence of depression is at its peak among women in the second through fourth decades of life, this twofold higher burden is invariant across the lifespan. So we see this 2-to-1 ratio in older women, just as with younger women alike. And there are serious complications of this excess burden of depression across the lifespan. In addition to suffering from the symptoms of depression itself, there's increased risk associated with depression of chronic conditions such as cardiovascular disease, and depression is itself also a risk factor for dementia. In this way, the burden of depression in which some women may have experienced since an earlier period in life can translate to this higher risk of dementia that's experienced later in life. And with regard to dementia, we know that women are also at higher risk than men. So of the nearly 6 million Americans currently with Alzheimer's disease, over 2/3 are women. And in fact, women represent over 2/3 of cases of dementia worldwide. And this excess is actually not solely accounted for by higher longevity among women. So while understanding this share of the dementia risk among women is certainly a very active area of investigation, I think a lot of people are increasingly paying attention to what role depression itself may have in this. But of course, it's also impossible for me to talk about dementia risk as well as gender and dementia without pointing out some really important disparities that we see in this regard, pretty consistently observed, both in the experience of living with dementia as well as caring for those with dementia. So first, several studies have shown that Black and Hispanic older adults have about a twofold higher risk of dementia compared to non-Hispanic white older people. So that, of course, translates to, in terms of proportionately, this greater share of dementia in that community among Black and Hispanic aging adults. And in addition, and this is something I definitely see every day in my clinical work, women are overwhelmingly most likely to be the carers of people with dementia. So by some estimates, more than 80% of all the informal carers of people with dementia are women. And as carers, women may be in this role at any age. So women may be juggling multiple roles, caring for a person with dementia who is older, caring for children or grandchildren. So juggling these caregiving roles in multiple contexts in a multi-generational way. And women of color, in particular, appear affected by this juggling across multi-generational roles. So having mentioned these important facts about depression and dementia with attention to life course perspectives and the intersection of gender with race and ethnicity, I'd like to say a little bit more in my last comments about the implications and the questions for us in terms of future study, what kinds of things we need to be looking at. So first, we need to understand a bit better risk factors across the life course for depression and dementia in women so that prevention can be optimized. For example, early life experiences of trauma and abuse may be risk factors for later depression risk. Using life course approaches, some of my research colleagues and I have recently found evidence that there is an additive, or what we call dose-like effect, of these adverse childhood experiences with the risk of depression in later life. So as the number of different types of adverse childhood experiences goes up, there's sort of a step function, a dose function of a higher likelihood of experiencing depression as an older adult. And preliminarily, there's some suggestion that the extent of this association may vary across different racial and ethnic groups. So understanding the details of risk factors across the life course is really critical in designing strategies for prevention or early intervention, and for doing so in ways that are culturally relevant to life experiences and can be culturally tailored. Second, I think we need to always keep strength-based approaches at the forefront as well. I've mentioned a lot about risk factors for adverse conditions, but factoring in both risk and resilience factors is very important. For example, we know that older women, despite all these challenges, actually demographically have the lowest risk of death by suicide compared to any other demographic group. By contrast, older men, the oldest men, have the highest risk of death, highest rates of death by suicide. So it's very important to understand in what ways women have resilience factors that potentially could be leveraged to understand how to better develop preventive interventions, particularly social and behavioral interventions. There's also a critical need for diversity in our approach to the study of these conditions overall. And this really requires increased inclusion of diverse participants, as well as diversity in our biomedical research workforce to ensure both scientific integrity of the questions, of the approaches taken, and that the work is community-centered and focused. Historically, in my field, Hispanic older adults have represented only 3% of the participants in the nearly 50 clinical trials of drugs for currently marketed treatments of Alzheimer's disease, more than 21,000 people in those trials. Black adults made up less than 0.5% of those participants. This clearly needs to change. Finally, in building out this public health agenda, it will be imperative to map out the risk architecture among sexual and gender minority older persons as well with regard to dementia and depression. There's been very little study in this area, but the existing data are showing very high burden of dementia and depression, both dementia as well as subjective cognitive decline and depression in older sexual and gender minority populations, and that the experiences of gender discrimination may be contributors. For example, there are reports that there are higher degree of subjective cognitive decline and depression among older sexual and gender minority adults. And that's important because we now know that subjective cognitive decline, or metacognition as it's carefully measured in research today, is actually independently associated or a predictor of future risk of mild cognitive impairment or dementia. So addressing this kind of inclusion in research is now critical so that we don't find ourselves yet again falling behind in the research knowledge because of the lack of inclusion today in clinical trials and clinical research of minority populations. So that will conclude my remarks for this presentation on Gender Conference. Thank you all for listening.
Thank you, Olivia. I can tell that we're going to have an interesting conversation around not only the interdisciplinary nature, but the expansiveness of the types of solutions we have to weave together to address the mental health crisis. Now, Esmé, it's your turn to give us your opening remarks.
Hello, good morning, everybody. And thank you so much to Radcliffe for having me. Before I start, I'd like to paint a picture of what it might look like to be a person living with a diagnosis of schizoaffective disorder, me, who sees themselves as very much identifying with their disorder. From an essay called Yale Will Not Save You, a funny title given where we are, I'm still trying to figure out what okay is, particularly whether there exists a normal version of myself beneath the disorder, in the way a person with cancer is a healthy person first and foremost. In the language of cancer, people describe a thing that invades them so that they can then battle the cancer. No one ever says that a person is cancer or that they have become cancer, but they do say that a person is manic depressive or schizophrenic once those illnesses have taken hold. In my peer education courses, I was taught to say that I am a person with schizoaffective disorder. Person first language suggests that there is a person in there somewhere without the delusions and the rambling and the catatonia. But what if there isn't? What happens if I see my disordered mind as a fundamental part of who I am? It has, in fact, shaped the way I experience life. Should the question be a matter of percentages of my lifetime, I've spent enough of this lifetime with schizoaffective disorder to consider it a dominant force. And if it's true that I think, therefore I am, perhaps the fact that my thoughts have been so heavily modeled with confusion means that those confused thoughts make up the gestalt of myself. This is why I use the word schizophrenic, though many mental health advocates don't. My friends with anxiety disorders, for example, tend to speak of anxiety as a part of their personalities. Laura Turner writes in her essay, How Do You Inherit Anxiety? It is from Verna Lee Boatwright Berg that I inherited my long face, my quick hands, my fear that someday soon I will do something wrong and the world will come to a sharp end. In their minds, there's no tabula rasa overlaid by a transparency of hypochondria, generalized anxiety disorder, or obsessive compulsive disorder. Such thoughts are hardwired into their minds with no self that can be untangled from the pathology that they possess. Another friend's obsessive compulsive disorder has calmed significantly since she began taking Prozac, but she continues to be most comfortable when things are tidy, even though her tidiness is no longer disruptive. She still washes her hands more thoroughly than anyone I know. There might be something comforting about the notion that deep down there is an impeccable self without disorder, and that if I try hard enough, I can reach that unblemished self. But there may be no impeccable self to reach, and if I continue to struggle toward one, I might go mad in the pursuit. I share this because I want to start with the idea that people like me, the people with the mental health issues, have all kinds of different ways of thinking about our mental health journeys. We can identify with our diagnosis and to see it as a source of strength, or we can be uncomfortable with it and try to distance ourselves, depending on the amount of stigma that we're facing at the time. This is something I've experienced firsthand quite a bit. For years, I worked in the world of mental health and illness and often faced questions about what it was like to disclose my diagnosis of schizoaffective disorder. Before publishing my book, The Collected Schizophrenias, which is in part about living with a psychotic disorder, it was more difficult to approach the topic of my diagnosis with people because I never knew when it was the right time to come out with it, and so I often kept it to myself. I remember meeting a classmate named Anna. On one of our first friend dates, we decided to go get coffee before seeing The Devil Wears Prada. Good movie, by the way. And I was incredibly nervous. So at the time, she didn't know about my diagnosis, and my diagnosis at the time was bipolar disorder. I felt like I had to tell Anna before our friendship went any further. So we were sitting there and having coffee, and I just kind of blurted it out. I need to tell you something. I have bipolar disorder. To my relief, Anna was incredibly kind and understanding. We're still friends 20 years later. And she revealed to me that she had an anxiety disorder, which had been debilitating to her for most of her life. So I didn't feel criticized. I didn't feel alone. I was, in fact, incredibly heartened by her disclosure and relieved at how she accepted mine. Over the course of our long friendship, she's ended up being a huge support as I've gone through hospitalizations and the evolution of various diagnoses. Unfortunately, such support and understanding isn't always the case, as we all know. Mental health is often portrayed in a negative light, with words like psycho and schizo being thrown around casually. To combat this, we can make sure to not use words like crazy when describing something ridiculous, and we can speak up when we hear others doing the same. It can be hard to speak up in the moment, but it is important to do so in order to create a more understanding and stigma-free world. So before the Collected Schizophrenias came out, but while I was writing it, I would notice stigma about my diagnosis coming from absolutely well-meaning people. At one writer's residency, no one knew about my diagnosis, and we were kind of going around in a circle reading our work. I read from an essay about the metaphor of demonic possession and schizophrenia, which also drew from my own experiences with involuntary inpatient hospitalization. And after everyone finished reading, one of the other writers there came up to me, and she'd always treated me completely normally, but she said, "It's so amazing that you're sick that way because you could never tell. You don't have those weird tics and things." At a fundraising party for my publisher, a donor came up to me and said, "It's so good to meet you. You're so eloquent for someone who has such a terrible diagnosis." And every time someone said something like this to me, I would have absolutely no idea what to say back. I would have no idea, particularly if that person was to remain in my life, if they would go on to see me differently. It always felt like a roll of the dice, because what was there to say in the face of this history of stigma, particularly when it comes to schizophrenia and other psychotic disorders? On the other hand, spending time around me was probably one good way to reduce stigma, because prejudice often dies in proximity. I should be glad that nobody thinks that I'm a murderer, because that's one of the few times I hear about schizophrenia in the news, when someone commits a terrible act of violence and it turns out that they have schizophrenia. Which is how we get to systemic stigma. So I fly a lot. I flew this year for travel to give talks, and I flew here to Boston. And other friends who frequently travel suggested that I get TSA pre-check to make traveling easier. And so I went through the form, and I came across question number 6. Have you ever been found by a court or other lawful authority as lacking mental capacity, or involuntarily committed to a mental institution? And at the top of the screen, it says, if you answer yes to question 2, 3, 4, or 6, you may want to reconsider applying. It's troubling to think that my mental health history could have an effect on something as bureaucratic as airport security, but it's a reminder of how important it is to work on destigmatizing mental health and on reducing the systemic stigma that people with mental health histories can face. But on a more positive note, this experience has shown me that on a lower level, anyone can get involved in local government with their expertise to try and make a difference. So my last story I want to tell is just about a few years ago, there was a debate in my hometown of San Francisco about whether or not to put a net under the iconic Golden Gate Bridge, which is a destination for jumpers. And I went to the city hall meeting. I never attended a city hall meeting before. It was interesting to observe the very archaic and traditional processes that had to be followed. But I spoke up at the meeting, recalling an argument I'd had with my husband years ago about having a gun in the house. I told him that I didn't want a gun around, in large part because I'd be tempted to hurt myself if it were there, as was mentioned earlier. A bridge made so available to suicide, I said, was not unlike that proverbial gun. I know that my story changed the mind of at least one person at the meeting. And ultimately, the city went ahead with building the net under the bridge. I urge you to get involved with your local government if you haven't already. In total, we all need to do our parts, and society needs you, especially when it comes to mental health issues. Thank you.
I really sincerely appreciated the three presentations because they so elegantly put together the numbers, the statistics, and the narrative. And I think that combination of numbers and narrative really opens up us all now for thinking expansively about this topic, mental health equals public health. So I'd like to begin with you, Ron. As a psychiatrist, you know just how poorly this mental health crisis in this country has been addressed, largely because, as you've said, misdiagnosis, and I would add misunderstanding, based on our panelists' beautiful presentation, and also mistreatment. And again, the example of the TSA is stunning. So I wondered if you could help us think through why it's been so difficult for our nation to address the crisis through an adequate public health lens and a public health approach.
One here. Yes, well, thank you very much for the question. I think it is remarkably timely and I think relevant for us as I hope I said earlier, are increasingly at a point in time, I think, in our country and many in our world where we may finally be giving a moment to thinking through how solutions may actually be relevant. But I'd say three things are primary impediments to moving forward. One, I think that the last speaker spoke, both speakers spoke very eloquently. I think about the issue of stigma. Mm-hmm. And stigma is a battle that we've been struggling with for decades. I think we do so because some people benefit by enhancing stigma against individuals who have brain-related illness. So educational programs like these are useful. But more importantly, I think persons have to kind of combat it in small increments in your own life. When someone makes a joke against someone, when a person who kind of laughs or makes little of a person's mental illness as compared to medical illness, we all should stand up and politely but gently make the rebuttal that that's really not appropriate. But I think it fosters, it continues misunderstanding, as you point out, which I think then next leads to mistreatment. Second, I'd say we just absolutely, as mentioned in the ante-room before, must put our money where our mouth is. We must fund programs and projects that equally value and benefit persons who have a brain-related illness. Early in my career, I was the medical director of a large state hospital, 400 beds, a place called Bryce Hospital in Tuscaloosa, Alabama, and it was just striking how difficult it was for us to receive even a modicum of resources for food, clothing, and shelter, let alone medications and care. Similarly, early in my career, we spent a decade arguing about whether we used some medications, whether they were based on their cost. Should we use the most expensive medications in psychiatry, so-called atypical antipsychotic agents? And often our rebuttal as psychiatrists was we wouldn't have this conversation if we talk about drugs or medications for cancer or heart disease or diabetes or the like. So I think that the value of individuals comes into play, and when our society and our government devalues individuals, whether you do it purposely or not, we see these unfortunate circumstances. My final point, I think, is this issue regarding the over-criminalization of the mentally ill. I'm a forensic psychiatrist by training. We've done this throughout a couple hundred years of American society, where often we employed our most adverse and hostile elements of retribution as a society toward and against individuals who have brain illness. We over-incarcerate them, over-criminalize them, over-punish them, and very often don't do so in a modicum of the rehabilitation that should occur in those type settings. we criminalize medical problems. Chemical substance use is a classic example. And I think that we have the ability to do that differently, to fund programs and projects that I think not only rehabilitate, but maintain, I think, the decency and the humanity of people. And I think psychiatry has the ability to make the argument that when we do so, we can provide care and treatment that enhance people's lives.
Thank you so much. That really brings me to the point of our having to really not be reductionistic as we approach this, but also be mindful of the point you made, Esmé, about the difference between interpersonal stigma that is experienced because of the daily living and the interactions with individuals. But then, as you've exemplified in the two solutions, we have to really start to dismantle the structural stigma, the systemic societal factors that continue to mistreat, misunderstand, and criminalize people with disorders of the mind, as you said, Esmé. Esmé, I'd like to ask you, you've spoken about your own lived experiences so eloquently, graciously, and I would say generously. And you've written a book, that is personal, but also includes cultural, scientific, and societal elements. Could you tell us a little bit more about the audience that you are attempting to reach? And I'd even say, what has been your observation about the impact of your work on the audience that you are focusing on?
Yeah, thank you. So the book that we're talking about is called The Collected Schizophrenias. It is an essay collection. So to kind of start off, it never was meant to be a memoir. It is marketed as one in the UK for whatever reason. I know the reason. They don't sell essay collections in the UK. But anyway, so the reason I wanted to incorporate elements other than just my own story, which is actually a criticism that a lot of people make of the book, is not juicy enough. It's not like, it doesn't have the drama of a memoir. But I wanted to incorporate all of those kind of research elements, like the science, the socioeconomic factors, things like that, because A, I am very bored with just talking about myself. And the other part, because I did think it was important to include those things to talk to this audience that I was imagining. And the audience that I was imagining was essentially anyone who would be willing to grapple with the questions that I wanted to raise in the book. So one thing that I joke about regarding myself is that I often joke that I don't have any opinions. But what that really means is that if you bring me on to a CNN show and I'm a talking head and you say, what do you think about involuntary hospitalization? I'm not really a person who is just readily going to say, oh, I think it's awful, or I think it's great. I'm the kind of person who likes to grapple with the questions, bring the questions to the reader and say, here's this side, here's some other factors. You can decide what you think about this particular matter. And so I've received lots of emails and I've met lots of people who've read the book who come from all walks of life, psychiatrists, people who are studying to be psychiatrists, people who have relatives who live with some form of the schizophrenias, people who have some form of the schizophrenias. And I think that the commonality between all of them is that they're willing to kind of grapple with these questions that I've introduced to them, and are willing to kind of think about it. And I'm glad to have those different groups of people be able to come to their own conclusions. Yeah.
And I'm glad that the publishers are facilitating your opportunity to reach those diverse audiences. Olivia, I want to turn to you. As a geriatric psychiatrist and as an epidemiologist, you have a really strong awareness of how mental health issues impact people across the lifespan, and your presentation was, a tour de force in helping us understand that. You've also spoken about the impact on women and the higher burden of depression and dementia in this segment of our population. We have a lot of research that describes the burden. And we have a lot more understanding about the intersectionality of these factors. Can you tell us a little bit about what is the barrier to bringing forward solutions in a way that really addresses the expansiveness of the crisis and also the concentration of need in some populations?
Sure, those are really great and big questions. And I'm sort of following up on the lead of what Ron was discussing in terms of the resource issue and where does that really come from. And I think in many ways what we see with the mismatch of burden and need with resources applied is it's a structural manifestation of stigma, right? You know, we look at all the ways in which historically this has been present within mental health. So we see that people have caps on the number of visits they can have. They don't have caps on the number of times they'd see their primary care physician. There used to be 50% copay on mental health visits. It was decades of a fight within the advocacy everywhere from professionals to patients, families, in combating this mental health parity problem. So there are just multiple examples of this. And so I think that on a societal level, there have been barriers that prevent us moving forward. I think another important barrier is when we think about some of the problems that I had been discussing, it's remarkable how they can't really be understood entirely on an individual level. And I'm reminded of the new National Institute of Mental Health Disparities framework, the NIMHD framework on addressing mental health, which is looking at individual level, community level, societal level, structural, and really integrating across all of these contexts the variables that come to play. And I think in terms of solutions, some of the really exciting work I've come across in recent years is kind of is harnessing some of that thinking. So it's person-centered, it's community-centered, it's culturally tailored, a lot of focus on behavioral interventions, on things that are not necessarily just medication-based interventions, lifestyle interventions, because one of the things we've also learned recently is that, particularly among communities of color, many older Hispanic and Black older adults in particular often prefer behavioral and psychological treatments if offered, compared to jumping first to medication-based treatments. And so I think a lot of the investment that it's been nice to see with the NIH in terms of funding research on developing behavioral and social interventions to address these conditions, depression and dementia, cognitive decline in older adults, I think that kind of points in the right direction, because when we look at the theme of this conference, how mental health is public health, it's because the scope of this is so big that the solutions really have to be addressing every level of every context.
So I'm gonna follow up. I have the opportunity, the luxury, the privilege of asking each of you one more question before we open up to the audience. But I want to follow up with you, Olivia, because we tend to be, the big we, tend to be reductionistic in our way of thinking and problem solving. And whenever the problem is big enough where a reductionistic approach is not working, we call the problem a public health problem, largely because we are unafraid of taking on the hard stuff. Have you seen examples where this, addressing the solution is designed to match the complexity of the problem and the multi-layer of the problem, the individual, the family, the community, society at large? Are there examples out there that we can point to and have some hope?
That's a good one. I mean,
It's
I think you make a great point. I mean, you could just as there are parallels to this in terms of addressing cardiovascular disease, in terms of addressing diabetes, in terms of
maternal
addressing
mortality, you name it.
Those are all lifespan, life course examples, and I think if there's a kind of a example of success, it's more along the lines of things that are not in mental health, right? So if there's a mission to the moon, every level of resource from every type of scientific discipline, every expertise is leveraged, right, to achieve this big goal. So I think all I can say is I can't point to an example at the top of my head, but I think that you're right in that type of thinking is just as relevant for mental health and probably for a number of other challenges.
I think you hit the nail on the head. Moonshot. I'm going to turn to Esmé. Esmé, like me, you are a daughter of immigrants. And, when you consider living with limitations brought on by mental illness, and I would probably amend that. I'd say living with mental illness, because there are limitations, but there are also advantages, I would imagine. How much of your lived experience was impacted by the fact that you're a first generation?
Yeah, so it impacted a lot. Thank you for the question. When I was in high school, the very first time I saw any kind of mental health person was my high school counselor. And I went and saw her in secret, and at some point she told me, your depression is so bad that you need to see a psychiatrist or something bad might happen. And so I went home, and the next morning before school, I told my mom, I've been seeing the counselor at school, which she didn't know, and she says that, I'm depressed and such and such. And so she responded in a very angry way, and so she just kind of yelled at me in Chinese, like, how could you do this? We've always given you everything you needed. You have a roof over your head. You have food. Like, you have, you've been taken care of. Like, how could you do this to us, essentially? And I just went to school and I cried, hiding in the art room in first period. And then eventually the counselor had to call my mom and tell her directly, like, there is something really serious going on. So I did end up going to a doctor. It was a psychiatrist, a white man, and we kind of sat there, and he asked my mom, is there a history of mental illness in the family? And she was like, no. And then much later, I realized this was very much not true. And my mom had been diagnosed with many things, and her cousin had killed himself, and my great aunt had died in a mental institution, all this stuff. And I asked my mom, Mom, why did you not tell the doctor any of these things? Because he asked specifically. And she was like, well, so these are not their matters. These are not things those are not these are our things. These are not the things that we should bring other people into. It's like a matter of saving face, and like a matter of like the stigma within the culture, the Chinese/Taiwanese culture. And so I would say that being the child of immigrants meant that, Western culture, American culture has its own stigma when it comes to mental illness or mental health issues, but then there's also this like added burden of stigma that comes with other cultures who have different kinds of stigma for mental health issues. In the case of my mom and her family, it was very much about like the Chinese notion of saving face.
Yeah.
And so, like for example, my great aunt who had died in the institution, lots of really awful things happened to her because the family was so desperate to conceal her situation from everybody around them. So yeah, it has brought to my mind the importance of things like having psychiatrists who are of different backgrounds. Like eventually I did find a Chinese American psychiatrist who was able to speak to my parents in Mandarin, which I think really helped. And also I'm very aware of like organizations like Therapy for Black Girls who specifically, have directories, or like Therapy for Latinx consumers, who are these directories that are specifically targeted at certain communities. And I think those are really important and great. And if you're a psychiatrist and you can join these directories to help people find someone who understands their background, those are a couple of my thoughts.
Thank you for sharing that. I think we might have a lot in common. Jamaican parents are sort of the same. You got to keep your, you have to save face. You have to put the strong foot forward. And what's telling about your remarks is how important institutions are. That you were in a school system with a compassionate and observant teacher is the first step. Thank you for sharing. So Rahn, I'm going to ask you, because you've also written books, and I think your second book deals with the horrible combination of gun violence and domestic violence. And, this is really a silent epidemic in this country. We saw and heard your numbers. What are some of the strategies that are out there that we have not implemented to help mitigate the carnage of both of these intersecting forms of violence?
Well, tremendous points. I clearly think that the scourge of gun violence is, the quintessential, battle of our time. Because it's an internally, localized problem. We destroy ourselves from within. I think it manifests a hatred that's at a higher level than we very often consider, especially as I think we see across the country. I want to speak about New Orleans next. We show it toward groups that have historically been protected, women, older persons, even family members, and increasingly now children. So I think it means a lot more than just the particular numbers, but I did jot a few numbers down anticipating this question.
Numbers and narratives.
I'm a numbers guy. National averages in this country are about 6 murders via gun violence per 100,000. In New Orleans, we're at 84, 14 times the national average. The number 2 city in the country is St. Louis, and they're at 42. So we're double the number 2. What I think is striking, though, is that what we put into people in society, we kind of keep getting out of them. I have a slide I didn't show it today. We're at 10 minutes. Great discussion. But the same 5 cities, New Orleans, St. Louis, Baltimore, D.C., and Memphis, that were numbers 1 through 5 in 2002, are the same 5, number 1 through 5 in 2022. So it's something that we are doing. Either 2-year-olds were doing it 20 years ago, or 42-year-olds are doing it now. It's always 22-year-olds doing it, but it's a different group of people. To me, that means a lot. And that's exactly why I think we have to consider public health considerations. We don't want to commend both your panelists today, just outstanding comments. I'll follow up on some of Olivia's comments. This idea, and use the term moonshot, is really the answer. I think we have to take this as a public health challenge. We have to use every valid resource that we have access to, education and health, public policy, some law enforcement. I don't speak against law enforcement. I think we need more, but it can't be over-militarized, and it can't be, I think, the only strategy or solution. But I think the big 3, as they are, I think, in many challenges in health, are education. People have to understand what the realities, I think, of these concerns are. One anecdote, I'm further conscious about training, and I often tell the story about the young man I had years ago who have a lot of variables, but you could fill in the blanks, but basically said to me in being interviewed, "Doc, if I'd known how much it was going to hurt to get shot, I wouldn't have kind of lived this life and been involved in what we all think is a gang-banging kind of life." So if we don't think that what we're feeling when we watch the evening news and we hear about a shot or a shooting last night in Boston or Baltimore or New Orleans or Miami, or many persons who are engaged in that lifestyle are not thinking it the same way, or see themselves as not just being, I call it a Bugs Bunny kind of life. You're doing that on Saturday and you get shot, but you're going to live through, you're going to be the same next week. Very, very different considerations. I'd end by saying I think that we talked during the COVID pandemic process about strategies to address issues to protect our entire country. And I think that that's actually a mindset that needs to be implemented in this thought concern. The reality is we had a long-term strategy. All hands were on deck. There really was no resource that was not accessed. I think I mentioned I just flew here yesterday from D.C. I'm on SAMHSA's National Advisory Panel, and SAMHSA speaks about how in 2 weeks they had responded to the COVID epidemic and began to change rules. We could, in mental health, do telepsychiatry. We've been trying to get that for years. We began, I think, find ways to implement strategies that access communities and individuals who historically we really couldn't access. So when we really put our minds to it at the government level with resource allocation, that was pointed out correctly, I think we actually can do much more, and we have to, I think, parlay some of those strategies to, I think, the gun violence battle. I think we have abilities to do so, but it's going to take, I think, a much more collective effort, one that's, I think, systemic and long-term, and one that I think we fund satisfactorily. But also, I think we should allow academics and academic information to lead rather than having, I think, what historically has at some point become a conflictual discussion of which either or. It should be both and.
Yeah, thank you. That's brilliant. And yeah, we did really see how we could mobilize and motivate change when we needed to do it in the crisis of a pandemic. If we can do it then, we can certainly take on these challenges now. So I'm going to turn to audience questions, and I want to remind everyone to, for those of you online, to include your questions in the chat function of Zoom, and those of you here in the audience to use Slido. So I'm going to start with the first question to you, Olivia, and the question is as follows: how do we combat or prevent dementia in older adults, especially women?
Yeah, that's a great question, and I particularly appreciate that because it's a focus in my work in particular is thinking about prevention. So when we think about how to prevent dementia or any mental health challenge for that matter, we can look at it in terms of individuals who are at particularly high risk, people who have risk factors, or an overall strategy, right? A universal strategy that everyone can benefit from. So when it comes to preventing dementia in women, it's definitely important to factor in individual level risk factors that can be optimized. So for example, we talked about depression. Optimizing mental health treatment is really important. We talked about lifestyle factors. There are a number of, this has been very, very well studied. There are a number of lifestyle factors that are sort of in this sort of list of top 7 of preventable contributors to a dementia risk, such as stopping smoking or not starting smoking, increasing physical activity, which includes leisure time walking. And there's been a lot of research among women and men, but specifically in women, showing that's beneficial. And then increasingly, we're looking at sort of lifestyle or multi-component interventions that look at diet, that look at lifestyle, that look at things that people can do individually as a group, that can be promoted in the community through community programs that can help to prevent dementia. So there's quite a lot. And just to bring back to numbers, because I know we like numbers and narrative. So when I talked about that top 7, what we learned about that top 7 is really important. It's things like maintaining healthy diet, social engagement, education. I mentioned the smoking, exercise. The reason this is so impactful is that managing those risk factors, so if you could optimize a person's profile in terms of those risk factors, you would remove 25% of all cases of dementia.
And cardiovascular disease?
It's true. It's a kind of a twofer. That's a really important theme with dementia, is that whatever is good for the heart is good for the brain, and vice versa. So yeah, there are a number of strategies.
We just got to get people to think expansively, right? All right, next question. And I'm going to direct this to you, Rahn. Given the gap in needed action and funding, and you've been talking about resources, so I'm going to call you the resource man.
All right.
Given the gap in needed action and funding from the government, what role can the private sector, I love this question, can the private sector or institutional funding play in addressing these challenges?
Private sector can play a huge role. I think private sector can actually lead. Clearly, I think that these challenges as it relates to healthcare in general, and healthcare particularly pertains to, I think, to women, many of the issues that I think are substantive or growing in the adversity they have toward women, domestic violence, you already mentioned. 3 things that come to mind. I'm in New Orleans now, and there's actually a council within the Chamber of Commerce that really meets to address a hiring construct. And it makes a lot of sense. I strongly believe that one way to decrease many people, whether they're teens or young adults, from being having idle time and engaged in adverse behavior, is to hire them and to pay them. One huge barrier has historically been that we don't hire and pay people who don't have an education, or who don't have a clean record, or who don't have a positive, who have had a positive drug screen. We've kind of got to get past that in a setting where I think many persons who are at highest risk of being victims of violent crime, let alone perpetrators of it, are persons who very often are disenfranchised, unfortunately, out of the employment-based systems. When we talk about workforce development, I think we have to be expansive, love your term, in that mindset, and find ways to do it, I think, that in ways that don't put persons at risk or violent risk, but find things that other young people can actually do. A huge point. A second point I think is also true is that all too often government programs start but they end, and we need sustainable funding. And it goes without saying it is a resource-based discussion, but when we have programs that work, when you pull the data, there have been incidents in this city or that one, kind of patchwork, a Band-Aid-like. Very often funding ends when governments change or government leadership changes priorities. Whether you're one color or the other, or state or federal, a few things are funded over time, and private sector has a remarkable ability to stay engaged if they feel like they're getting something out of it. I think a safe and communicable society, a huge point. And I think the third issue is I think private sector can be engaged as well in ensuring that these kind of educational programs are manifest for all. Warms my heart to see a full room here on a Friday at a university type setting, but I think people who are not in university also to hear these messages.
Yeah. I love that answer, and you really do think and respond to these questions in an expansive way, and I'll say that your arguments for the importance of engaging the private sector are so powerful, and we saw that in this pandemic. We saw the private sector mobilize its know-how on the ground and its influencing platform in positive ways. And we saw examples of how public-private partnerships can be transformative. And I think it's even more so if we engage with the academic sector as well. So I like to change the PPP, public-private partnerships, to PPAP, public-private academic partnerships. And then we can ensure that the progress made can be transformative and not simply transactional. And we can be sure that lessons learned are provided equitably to everyone who needs to have access to implementing solutions that work. Esmé, I'm going to ask you a question that you're going to feel like, why is she asking me this question? But I'd just love to hear your thoughts on this as the storyteller. What strategies are there to increase scientific equity in clinical trials that are racially and ethnically equitable?
So I used to be a lab manager, and I was also a researcher at Stanford. So I worked in the psychology department in the mood and anxiety disorders lab, and also the brain imaging lab that went with that particular lab, as well as the bipolar disorder clinic. So I'm not like completely unfamiliar with this kind of question, but I think it's difficult because there's the very nature of studies is to like get everything to, let's get all the factors to be the same. Let's make sure all our controls are completely clean. Let's make sure that all of the people that we're evaluating match each other as much as possible. And so it often defaults then to white people, usually white men. So I think it kind of might start at the very beginning when you're kind of initializing these studies. I have not started a study myself. I've only helped other people with their studies. So I'm not sure how easy or difficult that is to kind of diversify the population and to be able to do the science while also making sure that you're not just looking at the same kinds of people over and over. But it makes me think about, like, for example, my doctor had asked me to go get my 23andMe results. And so I did, but then I would see these results, and then like at the very bottom of whatever I was looking at, it would say like, asterisk, the people in this study were all white Caucasian men, like between the ages of 30 and 40. And I'd be like, I guess that means I'm supposed to take this with a grain of salt. Like, how big should this grain of salt? Should it be? The other thing I was thinking about that is not related to that question is like, there keeps being this analogy to reaching the moon and how everybody came together. We just need like a space race for mental health care. Like, can't we just get competitive with some other country about mental health care? And anyway, yeah.
Whatever works. So we're approaching the last question, and I'm going to ask each of you in a sort of lightning round respond to this question that was offered by a current public health student. Yay, public health students. And the question is, what can we do differently from a public health lens for those aging and already diagnosed with serious mental illness or acute mental illness? And I'll start with you, Olivia.
Okay. From a public health lens, I think what we need to make sure we do, particularly for those who are aging with serious mental illnesses, is we need to, thinking holistically again, thinking expansively, address all the things that are not mental health.
Yeah.
Because morbidity and mortality from non-mental health conditions can cut 20 to 25 years off of people's life. So that's where I would start. That's my lightning round contribution.
Awesome. Esmé?
Yeah, it makes me think about how when I was diagnosed with schizoaffective disorder, right after I'd been diagnosed with bipolar disorder for a long time, I realized that all of the resources I had available to me were for people who were just diagnosed or like were looking for a diagnosis. I had a really hard time finding anything for people who were like, had already been diagnosed and were like several years down the road. And I think that's a gap that's truly missing, as you were saying. Just like, what are you supposed to do as somebody who is aging, who has a serious mental illness? What resources are available that are beyond just the, here's what it's like when you're first diagnosed? You know, like, what does it mean to get older as maybe your symptoms are changing? Like, do we even know if symptoms change? Like, do things get worse? Do things get better? Or do you continue to be evaluated? Or do people kind of assume that it's like set in stone once you're diagnosed? I think all of these things tend to be like ignored as people get older once that like initial diagnosis happens. So that would be my answer.
That's a great point. Ron?
Briefly, I think we need an educated populace or society. I think we absolutely need early intervention strategies that I think have teeth to them. Third, I think we clearly need to fight against this issue of stigma, which really is rooted in fear. And I think that fear is manifest by many in positions that can be untoward toward others. And I think we need sustainable programs, mentioned funding earlier, that recognize that these are chronic considerations of chronic illnesses. Because they don't respond immediately to intervention, that means that the interventions are not worthwhile and worthy. I think those are key strategies that are likely to be helpful.
Thank you. So I hope you enjoyed this session. I certainly did. What a privilege to be on the panel with these three exquisite and highly esteemed professionals, artists, and care providers. Thank you so much. Really appreciated having the time to speak with you. And thanks for your attention and for your questions. I'm going to turn the stage over to you.
Well, I want to say thank you to this panel for such a thought-provoking discussion, which opens up so many crucial issues for our day's discussion overall. Thank you.